everybody. We are going to have a presentation about oncology services in Moi Teaching and Referral Hospital, Eldoret, from the year 2005 to 2020. And as you can see, the vision of MTRH is to be the leading multi-specialty hospital for healthcare training and research in Africa. Welcome, Dr. Moi Teaching. Our oncology services are based at the Chandaria Cancer and Chronic Disease Center, just for your information. And our mission is, as indicated there, I don't know who's moving it. Yeah, okay. That's our mission. The population of Kenya is 47 million by the 2019 census, the next one. And you can see that majority of the Kenyans are young, 0 to 14 years, they are 56%. And the population density on the next slide. As indicated, MTRH now we are celebrating 100 years since its inception in the 1900s, where we started with 60 bed capacity. As a national referral hospital now with 1,000 beds. We serve the western half of Kenya, encompassing 3 provinces, what we used to call provinces, Rift Valley, Western and Nyanza, with 22 counties and a population of over 20 million people. And just by way of looking at diagnostic services, the first outpatient department in an X-ray unit was built in October 1952. The next one. Oncology at MTRH, it evolved from an existing HIV/AIDS program. And as you know, MTRH has the largest HIV/AIDS management program in sub-Saharan Africa under what we call untapped academic model, providing access to healthcare. That's where our oncology services began, because it tended to occur that most of the patients who were coming for HIV/AIDS management had also some malignancies, particularly KS, Kaposi sarcoma. And we moved in 4 phases, where there was a limited pediatric cancer startup. Then number 2, development of an AIDS-related cancer agenda. And then number 3, a rapid expansion into a chemotherapy provision unit, and finally, a period of strategic restructuring into the present comprehensive care model. That building on the next slide that has been shown is our Chandaria Cancer and Chronic Disease Center, CCCDC, and it is really the hallmark of partnerships, strategic alliances and partnerships, and philanthropy. And we want to thank Dr. Moi Teaching, who is here with us. Is there, please clap for him, for contributing a lot to the construction and the partitioning of this structure, this modern facility. That's also where the office of the CEO is, if you can go back a bit. There's a C suite there, a corner office there. So thank you very much, Dr. Chandaria. So this growth has been driven by local clinicians and service demands. Therefore, we needed to get more partnerships to be able to do a lot more for the people. As it is, by the time of making this presentation, still, in MTRH, we are on the verge of starting radiotherapy services. Today, we are able to give screening services, surgical services, and chemotherapy. But I'll be giving you the story shortly of our radiotherapy services. So before 2005, the next slide, this department had 1 pediatrician, 1 nurse, and at that point we established a clinical registry for pediatric cancers only. And MTRH gave them a space for inpatient pediatric oncology care. And the outpatient was in another facility, not in MTRH. It used to be in Eldoret Hospice. And you can see the journey that we have walked, and I want you, as we trace, you will see the role of many partners in what we have done. We have not done it alone as MTRH. In 2005 to 2008, by that time we had 3 physicians and 3 nurses. So it had increased to that level with Eldoret Cancer Registry coming into being, pediatric oncology. I want also to say that this is the period, then I was an assistant director and we sent a number of doctors, nurses, and clinical officers to go for training in various areas. We started a training for clinical medicine, higher national diploma in oncology, and also a similar training for nurses. And we sent a doctor to South Africa to do radiation oncology, others to Alexandria in Egypt to do the same training. And I'm proud to say that one of them is here, Dr. Sarah Owino, if you can, yeah, she's there. One of the products of the period when we were sending a number of our doctors to go for training so that the numbers could increase. By the year 2008 to 2010, you can see the numbers was slightly increased. We also developed a multidisciplinary tumor board, which is very important for liaisons and consultations with other disciplines. And from, you can see the chemotherapy preparation and infusion tent, the next slide, before 2015, where we used to do it in the Ampath basement floor. Yeah, the next slide with a tent. Yeah, that one. We used to do it with the HIV/AIDS management services, and it was just a tent. You can see the way patients were being treated under a tent. The next one. In the next one after that again. Now, in 2017, at the Chandaria Cancer Center, you can now see it's a modern facility where patients are comfortable with reclining chairs for chemotherapy. From 2010 to 2014, the next slide, please. Next, yeah, that one. Now we have 3 physicians, 3 medical officers, 4 clinical officers, 6 nurses, 1 pharmacist, 3 pharm techs, 3 data staff, 4 research staff at this time. And we developed a number of algorithms for clinical services and trained nurses in clinical breast exam and screen and treat cervical cancer program. In this period also, there was an expansion into use of electronic medical records. We established a Gyn Oncology Fellowship, the first such fellowship in the country, in the East African region actually, with the first 2 fellows in training and assisted by University of Toronto in Canada. Yet another partner again that came on board to assist us. And we scaled up cervical and breast cancer screening with palliative care. The next. We also developed immunohistochemistry, multiple myeloma clinic, and other special clinics like sickle cell program, hemophilia clinic, supported by Indiana University. And by this time now, we had moved services into pediatric oncology, medical oncology, and gyn oncology, which were running successfully. And to date, the next slide, if you see the number of staff now that we have, they are more specialized, 3 clinical and radiation oncologists. I've already talked about this before. 1 medical oncologist, 2 peds oncologists, 1 medical physicist who had been trained by University of Toronto, and 1 hemato-oncologist, 5 therapy radiographers, and 2 anatomic pathologists. And you can see our journey in terms of infrastructure, in terms of HR, has been a long journey. And we have learned a lot of lessons in the process. Unlike, I know some institutions like our sister here, KU, they found a ready-made structure. And I think it is only a question of getting the HR. But us, we've started from a tent, literally, and walked the journey and got partners along the line, including Dr. Moi Chandaria, who came to assist us. So I want the next slide again, where we become a directorate. So in 2017, I became CEO in 2016, and in 2017, we converted the small unit of oncology to a fully fledged directorate of hemato-oncology. And that has many implications because it therefore becomes a budgeting center. It has its own director, and it can get more staff and more equipment and can write more grants and so on. So it was a strategic move to make sure that this directorate can do more, can be more enabled than it was before. And they are able to do all those services, the prevention, detection and treatment, palliative care, blood transfusion and nutrition, and also capped with research so that they can come up with new ways of doing things in a better way. The MTRH oncology, again, to date, in terms of facilities, the next one, there is one universal bunker in that Chandaria center for teletherapy megavoltage, one bunker for brachytherapy, and basically now it has become a comprehensive cancer center. And you can see the next slide, those are the bunkers, the brachytherapy and the linear accelerator. The next one. So our story about looking for funding to buy the radiotherapy equipment is a long one, but I will shorten it that we tried to get funding from the Treasury, but it wasn't possible for many years when the center was complete. And on the other hand, Dr. Manu Chandaria was always calling through State House to ask, when are we commissioning? And we couldn't commission without the equipment. That was in the agreement between MTRH and Dr. Chandaria. So we had to go to NHIF, our sister institution, through our cabinet secretary, and get a facility that is low cost at interest, in terms of interest rate. And we were able to start a procurement process whereby 75% of the costs are catered for by the NHI facility and 25% by International Atomic Energy Agency. The unfortunate thing about this is that it has taken 2 years to conclude the procurement. Otherwise, it was probably one of the best things that happened to MTRH because now we were able to get the funding for this much needed equipment. Those are the equipment as listed there: a linear accelerator, HDR Iridium 192, dedicated large bore simulators, CAM, and so on and so forth. And it is very difficult when you are dealing with a UN body because you have to also involve not only your parent ministry, but you have to involve also the Ministry of Foreign Affairs. And sometimes somebody in Foreign Affairs can make a medical decision, which is not what you require as an institution. So there were those opportunities which we were able to go through and learn a lot. And I want to say, as we speak today, our equipment has started arriving. CM already arrived a couple of months ago. Dosimetry arrived on Friday last week and is now ready for installation. The linear accelerator, which is because of the weight, it's almost 2 tons. It's being shipped and will be in Eldoret by 1st May. And we intend or plan to do the first patient, to radiate the first patient by 1st of June this year, God willing. Yeah, so please clap for us. Yeah, these radiotherapy services are very important for particularly the kind of cancers we see in this country, which present very late. And I want you to go to the slide that shows the types of cancers that we see in MTRH, because that is the next one. Much as we are able to do surgical oncology, we are able to do chemotherapy, but we need radiotherapy for very late stage cancers and even some early stage cancers. So unlike what is written in books, which we read in medical schools, and I'm happy I saw my young graduates are here. Please put up your hands, the ones who came from Moi. Yeah, these ones graduated last week, I think. So you will read in books that the commonest cancer is cancer of the breast, for example, but what we see in Eldoret is that the commonest is cancer of the cervix. This is now real, what we see. The data shown there is for the year 2019, calendar year 2019, 784 cases of cancer of the cervix to constitute 13%, and followed by breast, esophagus, all the others up to neuroendocrine tumor number 35 there. That's just 1 year, complete year. And you can see the caseload. The next slides, please. Yeah, over the years, the 2016 to 2017. The next slide after that. Sustainability, the next one. Yeah, there we are. So for us to be able to sustain the services, the most important thing here, even away from what is written on the slide there, is the fact that the staff of Moi Teaching and Referral Hospital, the human resources for health, their personnel emoluments or salaries are covered by the people of Kenya through taxes. The salaries are already paid for, so we are not necessarily going to charge the patients for the sake of paying the staff or staff compensation. Staff compensation, unlike in other institutions, like in the private sector, has already been taken care of by the taxpayer. So that makes the services highly sustainable on their own. I normally say, I don't know whether I'm right, that the only person who can run health services comfortably without straining is the government of Kenya. It is not very easy, and I know we'll be hearing from other stakeholders from the private sector. It's not very easy, ladies and gentlemen, running health services because majority of the people have no insurance and most of the people are poor. That's where we begin. And therefore, what happens is that we waive today as Moi Teaching and Referral Hospital, we waive 30 million shillings a month. People who are unable to pay, they can't pay and won't pay. And much as NHIF has tried, and today in MTRH 50% of our patients have NHIF cover, we still have challenges. We have very serious pockets of poverty in the region where we cover the 22 counties of the western half of Kenya, and sometimes all the way to Uganda and South Sudan. And I don't think it is any different even where KU and KNH cover. We have a lot of challenges in this country, and perhaps universal health coverage will assist a lot with this. So in terms of sustainability, government role is very important. NHIF comes in as number 2, but also we have to put in place poverty reduction strategies, series of poverty reduction strategies, looking into agriculture, education, and every sector in this country for us to be able to sustain these services properly. The next slide. One of the biggest challenges that we face is late presentation of patients with advanced disease, and I've already mentioned about that. And of course, now the other challenge about the equipment is being taken care of. So what is our future as I conclude is that definitely this is a sustainable service. It has taken us 15 years. Yeah, I was counting and it's actually 15 years from the day we started to today to be able to give a comprehensive package to patients. And therefore becoming probably the only public hospital that can give that comprehensive service today. And we would therefore urge more investors over and above government to look into this area. Cancer today is probably either number 1 or number 2 in terms of the causes of mortality. You could see those patients I showed. And therefore, more needs to be done to save lives. And we need to focus also, apart from treatment, where my presentation has heavily been on treatment, we must also focus on prevention. Prevention is equally important. Thank you very much.
Thank you very much, Dr. Aruasa. I think we can see that there's a lot that is going on in the public sector to take care of cancer patients. And in as much as we all hear about India, the truth is that the patients who can afford to go to India are just a small proportion of cancer patients in this country. The majority are still taken care of right here at home, and I think that was quite insightful. I would like to welcome Dr. Samuel Nguku to take us through his presentation.
Good afternoon, ladies and gentlemen. Thank you very much, organizers of this expo, for inviting me to give a talk on basically infrastructural development in cancer care through public and private partnership. And I would like to start by saying that I totally agree with Dr. Aruasa that when you have private sector leading the provision of healthcare, and this is similar to education, then really we are not doing very well. So I feel, and I strongly do, that for us to have a successful healthcare, then we have to have the public healthcare thriving or doing very well. I'll start my presentation by just having two subtopics. I'm a radiologist, so I do a lot of imaging. So I want us to do just a case study of, just a previous slide please, case study of PET-CT in Kenya, which is really a model of private public partnership. And the next thing that I would like to do is just to separate myths from facts as far as PET-CT is concerned. So just so we all understand what PET-CT is and what it entails. If you look at the National Cancer Control Strategy of 2017 to 2022, it has 5 pillars, and the 4 out of these really entail a lot of imaging. So if you look at screening, which is result in early detection, cancer diagnostics, cancer treatments and follow-up, and the last pillar, which is monitoring, all of these pillars will entail some form of imaging. So if you are to consider the aspects of comprehensive healthcare, as has been mentioned, screening, staging, treatment, and follow-up, all of these 4 spheres will require some form of imaging. So in terms of what we have available for imaging of cancer, the traditional ways are the first 4, which I hope most of us are familiar with. You have your X-rays, or radiographs as we call them. Then you have ultrasound, CT scans, and MRI scans. So all these 4 models really image what I consider, or what you call anatomical aspects of disease. So for example, you have a lump in your head, and you can feel it, then we take a picture of it, whether through X-ray or CT or MRI, and you're able to see the lump. But times have changed. What we are now trying to image is the cellular level. So we want to see what's actually happening to the cells before we can actually see the disease. So before the disease is visible, are we able to tell what actually is happening at the cellular level? And that's what we call molecular imaging or functional imaging. And nuclear medicine has been the hallmark of functional imaging, and by this we mean mainly bone scans and PET-CT, PET-MRI, and those kind of things. So PET does not stand for the normal PETs that we have in our houses, but positron emission tomography. And this is a form, as I said, of functional imaging. So it has been there for quite some time. If you look at literature and such history, since 1998 you had the first prototype in the US. The first commercial one was available in Europe in 2001. Well, it's a pity that we have taken 20 years to get one in the country. PET alone scanners, before you had the integration of a PET and a CT, was there since the early 1970s. So you may wonder why this hype of functional imaging, and I just wanted to show as an example here. So if, for example, I'm a radiologist, I'm looking at a CT scan, you've told me the patient has disease, so I skim through this scan and I can take forever to tell you, I don't know where the disease is. Sometimes I'll pick it, sometimes I may not pick it. So next, please. So if you look at the image on your extreme right now, that's a PET image. So the same patient, you see the black spot there, that's where the disease is. You could hardly see it on the CT, but now that you have a functional imaging or PET, you're able to identify where the disease is. Next, please. This is WHO assessment of the availability of nuclear medicine examinations in the world. And our country, Kenya, is somewhere in the middle here, where we have less than one nuclear medicine scan available for 1 million people. So if you look at Kenya in particular, the only nuclear medicine examinations available are at Kenyatta Hospital and at Aga Khan, which is a bone scan at Kenyatta and both at Aga Khan. Now we have a PET scan. When it comes to PET CT scanners, until the last year when we started scanning at Aga Khan, we only had scanners in the north and scanners in the south, and in the south, specifically in South Africa, in the north, mainly Egypt, Tunisia, and Morocco. It's a pity because, again, these scanners were there since the early 2000s. So after the first prototype in 1998, for example, Tunisia acquired their first PET CT in 2006. So you can see how far we have lagged behind. Next slide, please. So what was the effect of this? So the main thing, of course, is medical tourism. And most patients would go to India or South Africa or Europe to get their PET scans done for cancer staging or follow-up. And this was very costly. In the long run, it may be a cheap scan in India, but you have to pay for flights, accommodation, and all that, be accompanied by relatives. So it was very costly. For those who are not able to go, and a large proportion of Kenyans are not able to really fly out, they can't even go to the airport. It was expensive in the sense that inadequate staging, PET scans have been confirmed by multiple studies to show that they generally would upstage disease. And treatment planning and follow-up, the PET scans are very effective in treatment planning and follow-up. So basically it was very costly for patients who couldn't get it. They would either get inappropriate treatment or inappropriate follow-up. Next, please. So finally in 2018, we did have the first PET scanner. And you may ask why it took this long. Next slide, please. So the big question is, why did we have to wait all this long? Surely for a technology that has been there for 20 years and it's felt to be such useful for Kenyans, why do we have to wait 20 years plus? Next slide, please. And this is why. There's something called the cyclotron, and this is the big deal or the real deal when it comes to scanning patients. So the cyclotron is, I would consider it like a cow. So it produces the milk, and it's the milk that we need to do the scans. So the milk is what we call FDG, or fluorodeoxyglucose, which is basically a radio tracer or a radioactive substance bound to a sugar molecule. Unfortunately, it has a very short half-life, less than 2 hours, it's 110 minutes. So within less than 2 hours, half of the dose is gone. So within, if you produce a dose in the morning, by around 2 o'clock, there's nothing. It's all decayed if you have not used it. So what did it mean? You could get a PET scanner, yes, but you needed to produce the FDG locally, otherwise you cannot do the scanner. This is the most expensive aspect of PET CT imaging, the production. We have other tracers apart from FDG. I don't have to give us details of that. So the PET scanner is a combination, as I have said or alluded to, of a CT and a PET. So the PET is what images, takes images after you inject the milk, which is the FDG. So the CT is the normal CT that we know about, CT scan. Now you combine those two, so the PET tells you there is disease here because it will light up, and the CT tells you the disease is here because it tells you this is the brain. You know, if you just get the black and white image, you may not know, is it lung or heart, is it liver or bowel or intestine? So the CT gives you the anatomical aspect of the image. Down there is our PET scanner. So it's a large bore, it's about 70 centimeters bore. And the length of the bore is about, in diameter is 7 centimeters, the length is about 1 meter. Next slide, please. And so that we just understand a bit of why we use a sugar molecule to examine cancer, multiple studies, and this was interesting. Someone won a Nobel Prize for describing what's called the Warburg effect, is that cancer cells have been shown by multiple studies to use a lot of sugar compared to normal cells. So Basically, that's a very simple principle that we use to image. Unfortunately, as you may know, you need sugar for all your cells in the body, your brain, your heart, all the muscles, they need sugar. So you will have normal uptake of this FDG in normal cells. So the big question is to differentiate between them. And then the other unfortunate thing is that not all cancer cells take up this sugar. So there are some types of cancer that you cannot image with PET scan, with FDG PET scan. The other thing is infection. Any form of infection in your body will also increase the sugar consumption in your cells. Next, please. So this brings me to the big concept of private-public partnership. So where does this PET scanner come in? Because the main thing is you want it to benefit the people. And you may argue, no, look, this is set up in a private hospital. It was going to help only the or the people who are well off and are able to pay for scans. But I'll just show you in the next slide that that's actually not the case. So we have performed over 1,200 scans since we started last year in February, so it's about a year now. And if you look at our referrals, actually a majority of our referral base is outside of Aga Khan. A majority of those referrals are actually from public institutions. And the main reason is we have collaborated with the NHIF to provide coverage. I was telling Dr. Aruasa earlier that we get a lot of patients from Eldoret referred for PET scans. 10% are foreigners. Until we started providing this service, I didn't know there was no PET scanner in West Africa. So we get a lot of patients coming from Nigeria and Ghana, and also a few Americans. So you'll be shocked that it's very difficult to get some of these scans in America, and they're very costly. It costs about 700,000 Kenya shillings to get a PET CT in the US. So a patient would rather come down, have a holiday, and do a scan in the same time. So the indications of the biggest indication is cancer, and since we are talking about cancer, maybe I'll just leave it at that. Next slide, please. As Dr. Aruasa has also alluded, we read in books about different cancers and the prevalence. I did my training in the UK, and when we were starting our PET scan, I used to tell them, everyone, all the oncologists and clinicians, look, PET CT, the main indication is lung cancer and lymphomas. But lo and behold, these are our numbers. Breast is up there. Cervical cancers, which is what genitourinary malignancies, are up there in the list. Lymphoma, of course, lags a bit behind, but head and neck, lung cancer is not as prevalent here as we may read in textbooks. Next slide, please. So I just want to end my presentation by separating some facts from the myths. And probably the easiest one is that PET scanner is not for scanning pets. So the next slide, please. And it's not all indicated for all cancers. So if you have cancer, it's good to see an oncologist who will advise whether really this is indicated, or also liaise with us. And it does not treat cancer. When we started, I know patients used to go to India, and there was a lot of misinformation that PET scanners, they made me well, it doesn't treat. So it's staging or imaging modality that helps detect disease but doesn't treat. It is not useful for screening. You'll be shocked. When we started the service, we had very prominent Kenyans coming, wanting to have a PET scan for screening. It's not indicated for screening. I've put that in quotes because there is a small proportion of patients where we use it for screening, with something we call tumor markers, and they may be high, and you can't find where the cancer is, and you can use a PET scan to screen. So in terms of general indications, and these are established indications, main one is staging of disease, and PET scan has outdone all the other imaging modalities in terms of accuracy of staging. Most of the time it will upstage disease, and by that it means you will have less aggressive treatment, which would have cost you more poorer quality of life because of the treatment-related side effects. Very useful for treatment planning, response to treatment, and also for other non-cancer indicated indications which I may not go into details right now. In terms of preparation for the scan, not very difficult really. The main thing is, as I said, it's a sugar molecule we are going to inject the patient. So you don't want a lot of sugar in the blood system. So that's why we want to have the patient take as little carbohydrates before the scan as possible. Reduce strenuous activity, because if you use your muscles, then all the glucose we inject will go to the muscles and we can't see the cancer. And then of course you have to fast for a few hours to lower the sugars. And keep warm, because if you're not warm, then there's what we call artifacts or uptake in areas we don't want to have uptake. The actual procedure is straightforward. We put a line in the patient, we check their blood sugar, make sure it's within an acceptable level, inject the tracer, and wait for 1 hour, because you give it 1 hour for it to distribute to the body, to the areas you want to scan. And after that, we'll put the patient in the scanning room and take the scan, which takes about 25 minutes. Next scan, please. So in summary, basically this is what I've said. So you have to fast for about 6 hours. We inject we put a line or a cannula in the arm. We inject the FDG or the sugar molecule. After about 1 hour, we do the scans. Next, please. A few patients have asked me about, this scanner, you're injecting a radioactive substance. How harmful is it? It's a very small dose of radioactive substance. So radiation dose is relatively acceptable for medical imaging. So it's not worrisome. Then of course there's the other question, will I have a radioactive substance in my body? Am I exposing my children or the other people I'm in contact with? Again, this is very minimal exposure. Within, as I said in the start of my presentation, this milk is depleting very fast. Within 2 hours, half of it is gone. So by the time you're leaving the department, most of the FDG has been excreted. Are there any side effects? None at all. Actually, the FDG is what we call an inert substance, or something that doesn't affect any structure of your body. The other thing is sometimes some patients worry about the length of the scanning bore. You're afraid of closed spaces. But it's not as bad as an MRI, but still some patients would want to see the scanner and decide whether or not they are comfortable going in. So in summary, I would just like to say that the PET-CT has been a great model of how public and private sectors can collaborate to provide healthcare. I think the other thing is, look, we know that Dr. Google is very informative, but if you are going to browse, I always tell patients, please use reliable sites. And you have the National Cancer Institute, which is an American site of patient information, and you have the NICE guidelines, which is a UK-based site for patient information. Very useful and better information than you would get from just routine Dr. Google. Thank you very much for your attention. Thanks.
Thank you very much. Thank you, Dr. Nguku, for that extremely enlightening topic. It's not the pets we keep at home. It's all in contribution to cancer care. So I'm going to have a final presenter who's going to speak on a very sensitive topic, but this is what he's trained to do. We are taking care of our cancer patients at home, but are we adequately skilled? Where do we get support to make this happen, to improve the quality of their life? Please welcome Dr. John Weru.
Good afternoon. So, as we open up, how many of us have heard about a term called palliative care? How many of us have heard something called hospice care? Okay, it's a good number. And how many of us know where you can get palliative care for your patients and families? Okay, it's also a good number. So my interest is usually the issue of palliative care, end-of-life care. How do you manage pain at this point? And what are the ethical issues when you're dealing with patients and families when they are facing life-limiting, life-threatening illnesses? a caveat, palliative care is not only for cancer patients. Palliative care is for patients and families who are facing life-limiting illnesses. It could be cancer, could be dementia, which is becoming a very common diagnosis in our setting, could be multiple organ failures. It could also be other illnesses. If you see a patient who is 75 years and above with more than 2 illnesses, they require palliative care. But let's see what it is. Next slide. Okay, we're going to define, see what country status is, outline the challenges we face, and have a conclusion on the way forward. Palliative care. Next. So to differentiate between what palliative care is and hospice care and end-of-life care, how many of us know what the differences are? Or the difference is the same? So palliative care is an approach that you caring for patients and families who are facing life-limiting illnesses. So it is not defined by the age of the patient. It cuts across all ages, from children to adult geriatrics. It's not defined by the system you're dealing with, unlike cardiology, gastroenterology, and all that. It's not defined by the other specialization. And this gives us a very big challenge. Studies have shown that palliative care is the biggest field in the medical world. Now, if you talk about hospice care, it's that supportive care that is given to patients and families, usually in the Western world, in the last 3 to 6 months of life. And these terms are used because of Medicare, Med-Aid support. So the principles are the same. And end-of-life care is the last few days of life when a patient has cancer or other illnesses. Okay? So the next. So traditionally we've been having this dichotomy that you are treating a patient aggressively with aggressive treatment, and then towards the end, that's the time you're providing supportive, palliative, or hospice care. Today, it's known that as therapies to modify disease, as chemotherapy become less and less effective in treating this patient, as radiotherapy become less applicable to your patient, as surgery become no-go zone for patients facing cancer, the palliative care, supportive care should increase. So the dichotomy is now no longer existing. Next. And palliative care will be big from the time the diagnosis is made. Next. So it cuts across. It's very big. And in most developed world, what is happening is any patient diagnosed with cancer, whether stage 1, 2, 3, 4, they have to come in contact with the palliative care team. So that one, the concept of breaking news that you have cancer, the concept of having a big team taking care of you, the question of why me, why now is answered from the word go. If we wait until the end, then we have very short time to deal with patient issues and challenges. Next. Now, there are principles of palliative care, and this I think is good we understand, that life and death will come to us one day, one time. Our aim in palliative medicine and palliative care is not to hasten or postpone it. Our aim is to provide relief and manage symptoms in a very quality way, in a very timely way, and aim at the quality of life of the patient. Sometimes we deal with quality of life issues and think that quality of life is objective. It is very subjective. What makes quality of life of one patient is not what makes for the other patient. Some factors can cut across. For example, pain will take down someone's quality of life. But then the point and level of care might be totally different between two patients. Holistic approach is extremely important. And the core is the patient and the family. So teamwork is very important. And the support has to go all the way to the time of bereavement support. So essentially, palliative care is teamwork. You cannot provide palliative care, hospice care, or supportive care when you are all alone. When I sit in my office, I don't say I'm providing palliative care. What I say is I'm dealing with the symptoms that patients are facing. I'm dealing with communication issues. But when I deal with my counselor, and I have my social worker with me, I have my nurse, I have the pharmacist who deal with the strong pain medications, then I say we are providing palliative care. So it's about multidisciplinary approach, teamwork. Next. Now, let's go to country status. How many of us are aware that palliative care is entrenched in the Health Act of 2017, that it is the right of every Kenyan to access palliative care? As you talk about preventive, promotive, curative, palliative care is also part and parcel of that. And the second point to me is extremely important, that privacy and confidentiality are two ethos in palliative care and healthcare cutting across that must be protected. It's at the point of providing palliative care that patients are extremely vulnerable to breach of confidentiality and lack of protection of privacy. So we have resources. We have the National Hospice Palliative Care Association called the Kenya Hospices and Palliative Care Association. We have other resources that can assist us. We hold conferences every 2 years. We have documents that can assist. We've made a policy that is to be signed by the cabinet secretary, and then it will be consumed across. We also have all these units providing palliative care. We have currently 70 plus. We are tending to 80 hospices and palliative care units that we have. But next, okay, we have this. The WHO will estimate that 1% of our population will require palliative care at one time. Meaning if you have 47 million for 470,000. But the biggest challenge is only 10%. So we have more than 400,000 Kenyans suffering in pain and not knowing what they are suffering from. Dying in pain, dying in other distressing symptoms, distressed, no clear diagnosis, prognosis and communication. And the biggest reason why we don't have provision of palliative care to our people is one, that our capacity is wanting. That we only have, as a country of 47 million, only 3 qualified palliative care physicians. It means one should serve how many Kenyans? 15 million, eh? Is it possible? So capacity is extremely important. And sometimes we don't pay attention to what is the biggest pusher in the consumption of anything in the healthcare. It's the people who put pen to paper, the clinicians, the nurses, the doctors. Unless you improve the capacity, then you'll have a very big challenge. Others are knowledge and appreciation that palliative care can improve quality. Sometimes you don't invest in anything for monetary outcome. You invest to improve quality. Now, the other issue is referral system, the criteria, and when people get referred. I can tell you for sure, in a normal week, I'll see about 15 patients who are referred to me, but what I'm providing with my team is not palliative care, it's end of life. Because the last few days, I'll see only one patient who is referred early and come. People are going to work at the palliative care. So it is not end of life care. Please never equate these two. End of life and palliative care are totally different. End of life is a very small part of that. Okay? And notice that we no longer use terminal illnesses. What does terminal mean? Ed. We don't use it. Now, withholding and withdrawing treatment, a big question that we get asked by most patients and families. At what point do we stop the medications? At what point do we say that this is not going to be beneficial to me? We're still having patients who are bedridden receiving chemotherapy, radiotherapy, and other treatment. Unless they are for acute symptoms, you must ask yourself the benefit versus the risks and the side effect we are exposing our patients to. Advanced care planning. How many of us have heard about advanced care planning? You've not heard? How many? How many of us have advanced directives? Don't go, you're going very fast. Let's go back to the challenges. How many of us, do you know advanced care planning that says that when I get to a point where I cannot make my decision, this is what I would want to be treated by. This is what I would not want to be done to me. So the process is advanced care planning, and the outcome is advanced directives. All of us require to have advanced directives. Because when you come to that point when you can make your own decisions, then there might be issues of conflict. Then symptom management. Pain is a very big symptom. How do we manage pain in these cases? And how do we deal with opioids that the law calls narcotics and the doctors call opioids, analgesics? And we know the quagmire that we are in when it comes to these symptoms management. So that's a challenge still. The issue of do not resuscitate, artificial ventilation. As science develops, as medicine becomes more and more technologized, we get challenges on who should go for artificial ventilation, admission to critical care, investigations, futility of care. Who calls futility? The things we are doing. Shared decision making, who makes decision, and definitely communication. In palliative care, communication is very, very important. It's actually 3/4 of treatment. When it's come to next, at the end of life, we have very specific challenges still. And how do we tell prognosis? How do we tell these are features and signs that this patient we're going to lose this patient in the next 1-2 weeks? Are we still pumping our patients at the end of life with antibiotics and water and fluids so that they come and tell you, please, doctor, give this patient something? Are we still giving artificial nutrition and hydration to patients at the end of life when we know that their organs cannot function, that organs are shutting up, but pumping them with a lot of water and a lot of whatever? Are we still giving our patients at the end of life in the hospital a full chicken? You know, it's an end of life that we want them to feed. You've never bought me a chicken, but now you're bringing me 2. We need to understand that their metabolism is very low. They don't require. Okay? And then the issue of decision making, who makes decision? Do we know what the law says about decision making when the patient cannot make decision? The law is very clear. There's something called medical power of attorney. When you have advanced care planning and advanced directive, you decide that it's my friend and my neighbor who will make decision for me. That person is superior to making decisions for me than my spouse. So the medical power of attorney is, I'm superior, the medical power of attorney comes next, and then the other person, according to the law, is the spouse. And from the spouse, then we go to, from the spouse, then we go to adult children. And from then we go to parents and all that. Do we follow that? Do we follow that? Or the person who pays is the person who makes decision? Okay. Now, the other discussions we are having definitely is about physician-assisted suicide, euthanasia, and euthanasia is mass killing for those people who want to have a good death. What's a good death? And physician-assisted suicide is when you assist the patient to die. And we are also discussing so many other issues about symptom management, use of marijuana. It is us, we are discussing all those things. When you get those discussions, please, let's discuss them openly. Something we are having a challenge with is point of care and level of care and transition of care. Are we still converting our hospitals from acute care settings to long-term care? We need to accept the concept of home-based care. Long-term care should be at home, for example, and we recommend that highly. Next, what do we learn? We're learning that attempt to completely control life and death can become extremely dehumanizing. Patient stage 4, very sick, multiple symptoms, we're still ventilating them, putting them on those ICU machines. Sometimes try to control this. Gives us a question, a very big ethical question. What quality of life are we looking at this point when you're doing this to a patient with stage 4 disease? The other thing is the limits of medical technology and development. Some treatment could be burdensome. Please talk to your patients and families and make them understand. Never abandon care. Even if cure is not possible, there's so much that can be given. The supportive care that the patient and families require is extremely important. Sometimes we say that among the 4 principles of medical practice, autonomy, respect for autonomy, beneficence, non-maleficence, and justice, that respect for autonomy is superior. Sometimes we say that autonomy, especially in our context, is not supreme. It sometimes is limited. You are a rational human being who have got other stakeholders in your life. And we need to pay attention to your culture. We need to pay attention to the spirituality of this person. Social factors are also very, very important, including familiar aspect. How many Kikuyus do we have in this forum? Wakikuyu ni wagapi? How many Kikuyus? You need to tell me there are none here. And when you go to the streets of Nairobi, she's one of them. Traditionally, who was supposed to make decisions? Kikuyus. Who was supposed to make decisions? It was the man, the elderly man, and when he is gone, it's the firstborn son. And now you're saying that according to the law, it's the spouse who comes next to the holder of medical power of attorney. You're telling a community. So sometimes you have to be flexible according to some demands. Next. So in a nutshell, if you're talking about universal health coverage, UHC, that has become so common, and comprehensive health care, you cannot miss the palliative care and end-of-life care. They are part and parcel. You cannot have quality UHC without it. And in a country where 60-70% of public health care is foreign supported, by the way, to me, foreign aid is neither foreign or no aid. Because one day, one time, someone will have to do whatever. So for us to be comprehensive, we have to pay attention to palliative care, end-of-life care. Don't wait until it sets foot in your house that the time it will become your deal. Important values. Truth-telling never, ever hurt in medicine. It can hurt when you say you're going out and you're not going for Valentine and you find you somewhere else. But in medicine, when you're dealing with a sick person, it does not hurt. Care, respect, dignity. What is the quality of life that you're talking about? Honesty, empathy, compassion are key when dealing with sick people, especially when they are facing these life-limiting illnesses. Understanding the patient's perspective is crucial. Advocate for patient family right, multidisciplinary approach is important. And for the clinicians in this forum, the word is anticipation. Anticipate that this patient's requirement for support will go up. Communicate with the patient and also with the family. Because at the end of the day, holistic care is what we are looking at. Clear management of these symptoms and telling the patient what is and family what is happening. Thank you so much.
Thank you very much. Thank you very much, Dr. Weru. I'm sure I am a doctor, but I'm learning so much. So I'm hoping that all of us are picking up all these beautiful gems that are being shared. It's never over till we talk about the people who have put us on stage today. I would like to invite the sponsors for this session. They have walked this journey with us. They've been there for us. Just before we get into discussion and question and answer session, would like them to come on stage and tell us what their contribution to this very important sector of healthcare is. Please welcome Mr. Robert Nyasimi on behalf of Rentco Africa. Thank you.
Good afternoon, everyone, ladies and gentlemen. As the sponsor, the host has said, my name is Robert Nyasimi. I'm the CEO and founder of a company called Rentco East Africa. Rentco East Africa is an independent leasing company. So part of the intervention that we have in the medical space is that we are able to finance hospitals and medical practitioners to acquire equipments that they need to run their hospitals. Just to give you some of the examples of the hospitals that we've worked in, we've just set up the ICU and dialysis center for Kerugoya Hospital, where we finance them 100%, and that's the advantage that we bring in. If most of you have approached some of the commercial banks to get financing in regard to medical equipment, most banks or financial institutions do not understand how to finance medical equipment. So they'll tell you, you have to put in 30 or 40% deposit because they say, there's no second-hand market for medical equipment. So that upfront cash that you need to put up normally is a big hindrance. Then it means that you are not able to get the financing you need. Additionally, they'll always ask you for additional collateral, and again, that's an impediment. So where Rentco comes in is that not only do we finance you 100%, we look at that particular equipment as security. And we are able to finance you up to 7 years, depending on the quantum of the transaction. If the deal is big, it's MRI, we're able to do up to 7 years. Basically, what we try to do is to make sure that the revenue that you will get or generate from that particular machine corresponds to the lease payments that you're making. Just to run down, we are doing the ICU for Kikuyu Hospital. There's an imaging company called Sonia. We've given them an MRI. If you've seen the police ambulances, the Pujos that the police are using for both prison and the Kenya police, those are our vehicles. There are about 50 that we've given them on lease. Currently, I saw the guy from Moi. He's up here. He put out a tender for leasing of boilers. So that is something we are looking for. We participated in the tender we are waiting for. In Rwanda, we are just about to sign. Rwanda wants to start like a national ambulance services. For some of you who've traveled to most of these developed countries, you'll see that the government runs an ambulance service, so that when you call 911, an ambulance and a fire brigade will always show up. We are starting a scheme like that for Rwanda. We're actually at the signature stage, where we are doing 50 ambulances. But the scope is to supply 300 ambulances across Rwanda. So in a nutshell, what I'm trying to say is that Rentco, we offer alternative ways of acquiring your medical equipment. And feel free to come to our tent there, where you can get our contacts and talk to us. Further, if you are a professional, we can work through your association, because we understand about schemes and things like that. We are talking to the dentist board how we can get dentist chairs for all dentists in the country. Some of them come out of campus, they don't have equipment, they're just starting out. But if we partner with the association, then we are able to give like a scheme to the dentist. And so those are just a few of the examples that you do. With that, because I had not prepared a presentation, I just wanted to say that Rentco is an alternative, and you're welcome to talk to us. Thank you.
Thank you very much. So it's been an enlightening afternoon. What we'd like to do is give an opportunity for our listeners to interact with our speakers, ask questions, and let's be able to have an engaging conversation. So I think we'll have the microphone go around. And anybody who has anything to ask or seek clarification, this is your moment.
Thank you. My questions will be directed to Dr. Aruasa and Dr. Nguku. First of all, I would wish to thank Dr. Aruasa for the presentation. And I know from what is presented, 15 years is not a joke. I think the journey has been painful a bit. The journey has been painful. And 15 years is not a joke, and we congratulate you. My question basically is on an aspect of quality improvement in terms of moving from academia to the implementation stage. I know as MTRH, you have the benefit of academia through UNtapped and through Moi University. And I know throughout the stages, throughout the journey, you've had various studies, researches, be they operational, be they implementation, or be they at clinical stages. So my question would be, have you as an institution taken note of how long it has taken you to move from the academic point to the implementation point? Because I know most of the upcoming centers will be modeling upon what you have achieved. And the key sticking point we have in this country is that we take too long to move from the research point to the implementation point. So I don't know, as an institution, do you have that point of reference that it has taken us this long from the academia to our practice point? And to Dr. Nguku, the PPP model, especially for ensuring that we have these innovations or technologies with us here in the country, is usually a very great step. The challenge that we witness is usually on the access point, because the 3 Ps, there's 1 P, the private part. And as always, the private part will always be looking at what's in it for them, the profit aspect. And when you look at the profit aspect, it still makes these innovations quite costly for us. And at some point, even if you look at the NHIF, you look at the NHIF covers, they are fairly siloed or structured in a point that there is a national scheme, there is a scheme that covers a certain job group, there's a scheme that covers various, so you'll find that not all are able to get that PET scan when they need it. So what are the modalities in terms of that huge infrastructural investment that your team is putting in place or engaging the government in relation to improving access with the element of the private sector also talking about their profit? Thank you.
Thank you. We'll have another question.
Good afternoon. It's plausible the good work you are doing, even we can be able to tell through the presentation. But I just have a concern, or maybe it'll come out in form of a question. Maybe as Dr. Roka said, it's interesting how you're putting much effort to equip the healthcare worker so that even the outcome of the treatment can be much effective. But now the concern is that with all this upgrade of equipment and equipping the healthcare worker, the expectation is that maybe the cancer mortality rate should be gapped downwards, yeah? But maybe if you come back and confirm with the things that's going on the ground, you realize that in as much there's all this equipment and all this, but cancer-related deaths are still on the rise, and there are a number of them which go out and reported. Now the concern, what I'm asking that, what are you putting in place to ensure that there's awareness or sensitization down there? Because by the time the patient comes to the hospital, you realize the staging is even advanced. Now it remains with my brother who is taking care of palliative. Now I don't know what you're putting in place so that in as much we're working on our part on the other side of the bridge to equip everything. What about the public? I know there's a smaller bit that is going on of sensitization and awareness, but it's a very smaller bit. In as much from the medical part, you may think that the awareness is so much out there. But if you look at it keenly, it's very minimal. So I don't know what you're putting in place so that in as much we're waiting for the patient to come to the hospital, Are they aware of what's going on, where somebody can be able to tell maybe this is a staging or symptomatic of such? Thank you.
Thank you. We'll take one more. Let's make them a little brief so that we don't lose the speakers.
Good afternoon. My question is about how we can end medical tourism. We find that our politicians have no faith in the systems that they put in place for us. Like if a politician gets sick, they have to travel to England or even South Africa. I remember when Isaac Ruto got a scratch on the head, instead of just getting treated in a clinic, he had to be flown to South Africa. Does it mean that we have no faith in the systems that we have, even in the doctors that we educate? So my question is, what input in terms of infrastructure, technology, and professionalism do we need to stop medical tourism? Because there must be an existential challenge. Thank you very much.
Thank you for the presentations. I'll start with, I think it was Dr. Weru, about palliative care and the use of, well, not non-conventional, but alternative medicine. How is it that you're addressing the issue of pain management for patients who may want to seek alternative, whether traditional herbs? Now we know there are patients who are seeking cannabis, sativa, as an alternative, because either they don't know where to access palliative care. And as a follow-up question to that, what is the distribution of palliative care centers in Kenya? Have we reached the sub-county level? And then to Dr. Aruasa, I think it is, I hope I said it well. What have you taken into consideration the risks that come with equipment breakdown? About, I think, an year or 2 years ago, the radiotherapy machine in KNH broke down, and there were lines, huge lines of patients waiting for care. How have you addressed that risk? Yeah, thank you.
I think we can hold on and just have the speakers respond to those, and then we'll pick up in the next round.
So thank you very much, and thanks for the questions. I think I'll begin from this end where you asked about the role of academia and the journey that academia and care with research work together. And I'm happy to introduce that in the audience here we have Professor Tenge, who is the principal of Moi University College of Health Sciences. So just so that you know, wherever the principal goes, the CEO is there. And wherever the CEO goes, the principal of the college is there. So we work together very closely for many years. And in fact, in the last 15 years, it is not possible to distinguish whether it's academics that led or it is care that led or vice versa. That journey, there has to be a balance and you have to work it together. So it is not possible to say that we had the conceptual stage for this long and then started the care like this. Normally, our mantra there is that we say care leads and the others follow. In fact, it's not the other way around. However, we have seen situations where the academics also lead and we in the care follow. And I'll give you some examples. For example, even our cardiology fellowship. It's actually the care that led. We started a cardiology service and then later on we started the fellowship in cardiology. But in this one of oncology, we had the academia more or less lead and then the care followed. But you cannot really give clear and specific timelines. But true, a lot of research has taken place in between MTRH and Moi University, and a number of papers have been published, and even at the highest level of multi-center trials. that relate to cancer, HIV, and everything else. So based on that, we have had recommendations that have led to improvement in practice and policy. Not only at the level of MTRH, but even at the national level. We have informed a lot nationally because of what the work we are doing as MTRH, Moi University, and UNTAPPed. And in fact, UNTAPPed is just a medium that brings together MTRH and Moi University, and it is owned 100% by both institutions. And where the partners like Indiana University, they come in to work with us. It's a pot, a meeting pot where all of us meet and work. In terms of the mortality rates, I think somebody asked about cancer-related deaths should be now going down. And I want to say that that is true, and the biggest challenge we still face, like you saw in our presentations, all the way to palliative care, is that most of the patients present late, or rather, the cancer is diagnosed late. And this is why we've put in place some of the interventions like training nurses in oncology. This never used to happen in this country. Training clinical officers in oncology. So when they are working in the level 1, 2, 3 levels of care, they are able to pick quickly and refer upward all the way to level 6. We are also doing a lot of outreaches as MTRH. I'm aware also KNH, they do outreaches. We go to the community. We go and work with the county hospitals to try and do mass screening and sensitization of the population. However, I will tell you for a fact that there is still a lot of work that needs to be done, and I agree with you. We have a mammogram, a very modern mammogram in MTRH that was supplied through the MES program. And I will tell you, despite the staff population between MTRH and Moi University combined, we have almost like probably 7,000 staff. And majority of the population are female. Of course, even male also need to go for screening mammograms. But from the staff, we rarely get any one of them going for screening. These are our own staff. We have even had to work as a board to lead by going there to be screened, to have our, mammograms done in a way as to encourage the staff to also go for the same. But it's never easy. So we need to sensitize people. We even need to carry out studies to understand why do people behave that way. Right now, our Department of Radiology and Corporate Communication, they are working together to do a study and understand why is it that people are not going for mammography services even when they are available. Why aren't they going for screening for prostate cancer even when those services are readily available? So all these are opportunities, and we need to work together. We cannot, in the health sector, pretend that we can work on our own. You need to assist us through sensitizations, even through blogs, even through, WhatsApp, social media, and other ways of sensitization. And particularly the counties, the lowest level of healthcare has a lot to do on this matter. This is even what we were telling the counties also when it came to coronavirus, that they shouldn't think of KNH, Mbagathi, and MTRH alone. They have a lot more to do in terms of proper messaging, health messaging to the population about what we are hearing about hand washing and respiratory hygiene. You don't need MTRH or KNH to do that. The counties can do that much better. So the counties, and as you know in Kenya, health is a devolved function basically. In fact, it's probably only 5% that is national. And the counties must do a lot more. Sensitization, public awareness campaigns for cancer, and all other diseases across the spectrum. Finally, I think there was an issue about medical tourism first, and why we still see a number of people going abroad. And I think probably the number might have stabilized now because the Ministry of Health has a desk now that deals with all patients who are going abroad, and the statistics don't seem to be rising that much. Most of the services that people used to go abroad, including PET scan, is now available in Kenya. And the numbers that Daktari was showing for PET scanning, I'm sure those would have gone abroad. So as we avail more of these services, I'm sure it will reach a point in the not too distant future, perhaps in another 5 to 10 years, where we'll have very few cases who are actually referred, if maybe for another opinion or something else, but not necessarily to go for primary care. And I will tell you, in some of these services like kidney transplant, open heart surgeries, which are now available and properly done in Kenya, we have seen patients who went abroad, they had the surgery there, and they were not properly informed about follow-up. So one of the biggest challenges that we are facing is poor follow-up and poor communication to the patient and the family. Whereas, of course, there are many things that we have learned from the practice of medicine abroad. For example, working as a team, group work and discussing a patient. In Kenya, we tend to go solo, which is not good. So there are some things we have learned, and I think as we adopt all those strategies, there should be no good reason for anyone to go abroad, except in some few instances, definitely. And then finally, in terms of our equipment, I will tell you one of the biggest challenges I saw in the counties, why some of the MES equipment has not been deployed, apart from lack of human resources. The other biggest challenge is to do with electricity and maintenance of equipment. We long learned that for every equipment that you deliver, that you bring, you must have an extra equipment as a backup. Number two, you should not even be talking about UPS, in terms of protecting an equipment from unclean power. You should be talking about having what we call an automatic voltage regulator. And the entire power regulation system must be okay. Number three, you need to deploy and have an electrical engineer. As MTRH, in the last 5 years, our board had to hire electrical engineers to better take care of our equipment. And I can tell you, from where we used to lose a lot of equipment 10 years ago, to unclean power, that's a thing of the past. Just by putting in place those strategies. Finally, every equipment, particularly of high value, must come with a comprehensive service maintenance contract. And I want to assure you that we do just that. You have seen that there is one linear accelerator that is being delivered, and a brachytherapy and dosimetry. We have a similar, just like a copy of that we are going to plan from the next financial year. And the Treasury has already allocated funds to build 2 other bunkers and to get those equipment. Because we put in a very strong case that it is very dangerous to have one equipment only. Thank you.
Thank you very much, Dr. Aruasa. I think you have answered more or less most of the questions. I'll just address the issue of access and costs when it comes to PPP. That's private-public partnership. Now, if you look at the costing of PET scan, which is about 70,000 shillings at Aga Khan, when we were starting off, because I was involved in the process of basically installing this machine, the initial projected costs were way over 100,000 shillings per scan, because that's what it costs down in South Africa and Egypt, which are the main countries that are near us. Of course, it's cheaper in India, and the issue is, the reason is you have more, it's more accessible there, so the market plays, so you have a cheaper machine because it's more accessible. Now, initially, NHIF did commit to be doing full reimbursement of the costs. And when we started off, the first few months of last year, I was the most happy person because I could see low-income Kenyans, patients who cannot actually afford even a CT scan or an X-ray, coming through for PET scans, fully paid by NHIF, making a difference in their lives. That has a bit changed. There are some challenges that we have had with the scheme, which I think it's affecting most of the coverage in terms of reimbursement. And we hope that things will improve with time. But the other thing that happened is, I think the numbers that we have seen of patients requiring PET scans has gradually increased. to a point where maybe NHIF did not anticipate, because when they committed to do this kind of full payment, maybe thought we have been referring about 10 patients a month to India for PET scans. But once the service is available, definitely the need increases and the numbers increase, so the numbers are very high. But we hope that the national scheme will keep up to that promise and keep paying up the full amounts. As you said, the different cadres of people with whose care is taken care of by NHIF have different coverage. So if we still have patients who have comprehensive coverage getting full reimbursement, but a majority will get maybe half of that and they will have to top up. So that is a true challenge, and I totally agree with you. It should be more accessible, and we do hope and pray that the stakeholders involved are doing the necessary, making the necessary plans and regulations to make sure that this is sustained. Thank you very much.
Okay, thank you. I'll start with the question of diagnosis, late diagnosis and late presentation. It has been shown that patients don't present to health facilities late. The biggest challenge we have is the fact that we don't have the skills that when patients present, we don't raise a red flag. So a patient coming with a swelling, a small swelling, what would make that clinician go a step further and investigate that small swelling? A patient coming with vaginal bleeding, for example, what would raise a red flag for that clinician to go and do further investigations? So patients do present early, but it's the diagnosis that will be made late. And from this finding, in the last 2 years, there has been a consortium called Blueprint for Success Project, which is funded by a pharmaceutical company called Takeda, with partnerships between AMREF, National Cancer Institute, Ministry of Health, Elewa Cancer Foundation, and Kenya Hospices and Palliative Care Association, with the aim of training healthcare providers, primary healthcare providers, to know what they need to do when they see a patient who has any symptoms, yeah, to improve their skills and all that. So the first county we dealt with in this project is Meru County. This project is now ongoing. Remember, Meru County has got a very high incidence of cancer, especially the gastrointestinal cancer. So studies have shown that there could be reasons why it is happening there. The next county from Meru we're going to is Makueni County. And this now has started. So how do we influence the attitude and the skills of healthcare providers is extremely important. Now let's go to the issue of palliative care. We have about 70 plus providers of palliative care in government institutions, in private institutions, and in hospices. The distribution is, we have these units. We are currently mapping them, but what we know is within the central province, we have them. Within the central Rift Valley, we also have hospitals and palliative care. Within the former coast province, we have them, western and eastern. And northeastern, we have 2, which are not enough for such a vast province to have. The big question is, how are they manned? Who have we trained? Do we have the capacity to provide what is required? Do we know what palliative care is? Because if you equate palliative care with pain, then you are not providing palliative care, you're providing, that is, issues of anesthesia. If you equating palliative care with counseling and all that, then that is not palliative care. So that is the distribution we have. The question we have now is, the policy, once it is signed, the implementation will be key in having palliative care services across board. And since the policy is ready just to be signed and implemented, then the government will have to deal with it. Both the national government and the county governments in improving access and availability of palliative care services to patients and families who need. I usually say that if every level 4, 5, 6 had palliative care services, the access will be to about 50-60% of those who need this service. Coming to the question of alternative medicines in management of symptoms, and the biggest currently is the question of marijuana. Once you talk about something and then politics come in and we don't define what it is, then we lose it. People don't know the difference between cannabis sativa, which is the plant, and cannabinoid oil, which is the extract of the plant and which has been shown to have effect on fatigue, on pain, on nausea and vomiting, and generally improving what the patients feel. So how many of us know that as a country we have a quota from the International Narcotics Control Board to import 1 kilogram of cannabis? Do you know that? Now, when you talk about cannabis, and you're talking about cannabis itself as a recreational drug, then the law will not agree for it to come in because of the issues of abuse, misuse. But if you go on the side of cannabinoid oil, which has been shown to be effective in managing some symptoms, then we can argue. But by the time we are using it or prescribing it, the law must align to that demand. Okay? So it's a big issue. We were with the Pharmacy and Poisons Board last week, but one. And the Kenya Pharmaceutical Society have talked about it. They would want it introduced. The government was to meet, I think, next week, the cabinet, about how do we deal with these issues. The legislature has been talked to, but at the end of the day, we differentiate between cannabis and cannabinoid oil and its effect. Where I did my fellowship, cannabinoid oil is used. And I noticed that it improved this patient's well-being, pain, nausea and vomiting, and fatigue. And the way they used to do it is DOT, directly observed therapy. So they used to go to the institution, they used to come and get their doses and all that. So these are discussions that we are going to. But any other complementary support that the patients might require, we need to discuss about it. So it is a very crucial point on how we can assist the patients overcome their symptoms and all that.
Wow. So much medical terminologies being spoken here. Okay. For me, I'll handle something to do with how to end medical tourism and equipment breakdown. From a financing point of view, you know, sometimes when you just want to go to India or Israel or the US, is because you see in those countries, you tend to get newer medical equipment than what you get in Kenya. In fact, the last time I was in Finland, you get like an MRI or some of this imaging equipment. If they are older than 5 years, you know, the insurance can't cover them. You, as a practitioner handling that equipment, you cannot get your professional indemnity. So what it forces them is to always refresh that kind of equipment. And when that knowledge gets to people like us, so you believe if you go out of the country, then you get you get attended by good medical equipment. So I know the medical equipment or the managed equipment program has had a bit of critiques here and there, but it's a good problem to have. First, once you have the equipment, then you sort out the personnel, you are halfway there. And that's what I kept talking about, what leasing can do. Because you are able to get this equipment. Equipment breakdown happens because of obsolescence. You're keeping an equipment for too long. Generally, when you buy something and you own it, you tend to keep it longer than its useful life. However, on a lease, you'll get the leasing company, if it is a 3-year lease, 5-year lease, when it's approaching the end of term, will actively tell you, this equipment has come to its end. Can we replace it for you? So you are able to make a decision. But when you own it, you just see it is there. I am very sure most of us here, you have so much things in your houses you don't need, just because you own them, but you don't use them. But if someone came and told you, this one has reached the end of life, you'll actually find a situation whereby you are replacing that equipment. Then the other thing that we do to ensure that machine breakdown does not happen, or what the hospitals can take advantage of, we have a scheme that we've used it on the IT space, basically on the laptops and computer equipment. We have an exchange plan. For example, if we give you medical equipment, and 2 years down the road, new equipment comes, we can come pick up the old equipment, give you new equipment, and if you are paying X per month, because it's a rewrite, your rental remains the same, but you have new equipment. Then we take that equipment, say it was for Moi, where they need high-end equipment, we take it to level 3, level 4, who are able to use it for that matter. So you're moving it from the higher, people who need the latest equipment, you're taking it to those who might find value in that particular equipment. The other thing that we have to appreciate, technology is an expense, it's not an asset, and that's how you must treat technology. It's not a house, it's not land that appreciates in value, and that's why you need to lease it, you need to rent it, yeah? So the moment you look at technology as an expense and as not an asset, then you're able to take advantage of a leasing program. Finally, this PPP that you keep hearing about, you can actually debunk what a PPP is all about, because I know most people, when they hear about PPP, they think about a big hospital, you're putting up a big infrastructure. But a PPP comes down to, even if you're providing tea in a hospital and you are probably doing a revenue share, that is a form of a PPP. Yeah. Sometimes I get doctors, like I have a good example that we have financed, Jamu Imaging, who are doing placement. They are radiologists and they go to a hospital like Nairobi Women's. They want to put an equipment there, then they share revenue with the hospital. Yeah. And what we help them do is that, you structure the contract in such a way that it is bankable. So the lease agreement that he has with us, vis-a-vis what he has with the hospital, gives certainty that a financier can look at. So if we equipped hospitals, if we have the latest technology, we can put an end to medical tourism, we can avoid breakdown of equipment, and keep at the edge of technology. Thank you.
Thank you very much. Do we have any more questions? Oh.
Okay, good afternoon. Thank you very much, panelists. What I want to ask is directed to Dr. Weru. You've talked about palliative care on the issue of access. I think that has been well addressed. And the issue of training people to offer their palliative care. I think you have described that as the policies coming up. what I really want to know is that whether the issue of affordability has been addressed. Because the complication we normally have with patients is that by the time they are going for palliative care, they have been put through a lot of curative therapies, which is quite expensive, and they are trying to balance between whether to go into to get another course or just go for whatever is they are already going through. So my question is, how are we addressing the issue of affordability because of the dilemma of the continuing treatment and the new costs? Thank you.
Thank you. Any other?
Thank you. My question will still go to Dr. Weru, and it is a rejoinder to what has just been asked about issues of affordability, because I have always been wondering that whenever a hospice is supposed to be started or palliative care is supposed to be started, you realize that there is a lot of limited resources, to the extent that always fundraising must be done. And from the many years, even where we worked with Dr. Weru back in Nyahururu, I know when they started the hospice, me and him contributed. And this has been the trend, even where we are finding we have less hospices, like the way you have mentioned about the lower eastern region. It could be the issue of resources. So I don't know if the policy is addressing issues of resource mobilization to have these hospices available and reachable to the common Mwananchi. Thank you.
Thank you. I think we can have Dr. Weru respond to that.
Thank you, Dr. Kiuli. That gentleman was my classmate as I did medicine and did pharmacy, so we sat down in some initial classes. And you ask a very important question about affordability. And studies have shown that palliative care is a very low-cost service that is provided. The biggest challenge we get is the point of provision. So the site of provision, you can have it in hospital or in hospice, nursing homes, and even at home, determines the eventual costing. Because in hospital, it will be just like any other service. Our hospitals have not bought into this aspect of having set beds and sites for palliative care. So the charges will go still the same. For example, a consult for a review will still be the same for palliative care patient compared to a patient on active oncology treatment, compared to a patient who is at the cardiology, compared to a patient who is seeing a surgeon. And that should be different, and that has to be worked on. The other question that we get is the cost of medications, for example, the most important being the pain medications. The cheapest is the drug called morphine, whose cost right now is about 300 shillings for 300 milligrams of morphine itself. We're talking about the liquid. And depending on the availability of the tablet, then it will depend on the market forces. Remember, we are in a free market, the willing buyer, willing seller, and that should be controlled. But we have a problem because in the last 2 months, since January, there has been introduced some taxation for this opioid. This is something we are discussing with the government so that there should not be any taxation added to this crucial pain medication. The other thing is the other pain medication like oxycodone and fentanyl, their costs are way too high. They cannot be afforded by most of the Kenyans. And the question usually comes in the retail and the flow and the third parties that deal with these medications. We also have a challenge because NHIF does not support palliative care services. A big challenge. We're talking to NHIF so that if other services are being supported by NHIF and these people have been paying, then they have to access it. For me, what I say is this person is sick. I'm dealing with a person who's been paying NHIF, and I still fill those forms. Sometimes you have to call them and tell them this is someone who's been paying you. And should it be free? Should it be a package? And I think that is the question you're really asking. I think for this crucial service, the patients and families have used virtually everything, all the resources they have had. We've had families use 3 generations of accumulated wealth to treat someone who might not be cured. So how do we mitigate that? I think it should be a package. Should it be free? Of course. Healthcare should be what? Should be free, should be accessible, and the government need to make it also affordable. I was looking at this new issue of UHC being available in those few counties. How many of us have realized that even the simple medications in those counties are not available? But you are saying we are piloting. If you are piloting negatively, then don't go to the main project if the outcome was negative. So that is where we are. It can't be a package. It needs to be provided at a very low cost, the medications themselves. And also once we increase the personnel and the capacity, we can improve that. Now, based on your question and his question, my colleague there, the policy addresses 4 main factors. One of the factors is about infrastructure and the concept of palliative care units within the government hospitals. The second and very important is the personnel and training. So the policy talks about training of palliative care specialists all the way from the doctors to the clinical officers, nurses, and other auxiliary support staff, including social workers and counselors, and also pharmacists who deal with opioids. The other factor that deals with is the transition of care. Where can it be provided? Are we allowed to, for example, do blood transfusions at home? The law does not. But this policy is saying we need to be flexible such that if you have teams that can provide palliative care at home, then they're able to provide the whole spectrum of what is needed at home with the support of their parent institutions. And lastly, it is the incorporation and integration of palliative care from primary health care all the way, both academically in the training institution, so modules are being introduced and topics, and also clinically. So those 4 aspects are in the policy. And once it is signed, the implementation process, now there are people who are ready and willing to support the implementation. Fathers have been talked to. And the last thing that this policy, and most important, is that some money is being set aside from the national government budget to support palliative care in all these 4 aspects. So that will come in very strongly. But we need to build on what we have, because already we have something. How do we increase into it? How do we avoid these issues of saying we don't have medication for patients who are suffering at the end of life? For example, painkillers should never, ever miss for this patient. Thank you.
Thank you very much. I think it has been an amazing afternoon. Why don't we have a round of applause for our presenters? And let's appreciate them. I'd like to call upon Dr. Elizabeth Walla to please come on stage and give them a small token of appreciation, as we'd like to thank them for being in this panel. Thank you.
Thank you very much. On behalf of the organizing team, we appreciate that you took some time to come and educate us, tell us more about what you are doing in the sector.
Thank you. For Dr. Wilson Aruasa. Thank you very much. Thank you. Keep Moi Teaching and Referral Hospital shining. They're already trailblazing. Let's all support them. Thank you. For Dr. Nguku, Dr. Samuel Nguku from Aga Khan. Thank you very much. We absolutely appreciate your presence here. For Dr. John Weru, he's very passionate, don't we agree? Thank you very much, Dr. Hari. And finally, to Mr. Robert Nyasimi, the future of healthcare is definitely in leasing. We advance in technology, we go digital, all our digital equipment becomes obsolete extremely fast. So we have no choice. We have to think around what is the best way to avail this equipment and make it useful for our patients. Thank you very much. Thank you too for being an amazing audience. It's been a wonderful afternoon. Tomorrow morning, we start at 9 o'clock. You're all welcome. We'll be talking about everything maternity, maternal health, pregnancy, childbirth, pain relief. It's an amazing discussion. Thank you all, and we hope to see you tomorrow. Asante.